Dr. Mike Abecassis was kind enough to come over from Northwestern to speak to us today on the topic of, is there an ethically acceptable threshold for live donor risk? I was telling Mike that this is a question that has concerned me and troubled me since the mid-1980s, when we began to consider working here on the Living Donor Liver program. And it's a question that until today's talk has remained unresolved. But Mike promises me that we'll have an answer. As you can see, Dr. Abecassis is the J. Roscoe Miller Professor in the Departments of Surgery, Microbiology, and Immunology, the founding director of the Comprehensive Transplant Center at the Feinberg School of Medicine at Northwestern. Please join me in welcoming Mike to our seminar.
Thank you. So first of all, thank you very much for inviting me. It's really an honor to be giving a talk related to live donation in the birthplace of live donation for liver transplantation. And as I was saying earlier, you guys did it right. You got the ethicist involved very early before you actually did the first live donor transplant, and the rest, as they say, is history. So it's really an honor for me to be here. Let me see. So first, a couple of disclosures and disclaimers. So I'm a transplant surgeon who performs live donor procedures, and therefore I and my patients benefit directly from live donor transplantation. So that should be a disclosure that anything that I say is going to be biased. I consider myself to be ethical, but I am not an ethicist. I represent my own views and not those of any group, organization, or institution that I am affiliated with. So I thought I would start with stating the obvious. Hi, Peter. How was the adrenalectomy? Good.
5 minutes late. But.
So these are just some facts that I would like to get on the table, and if anybody disagrees with these, I'd be happy to have you jump in and say you disagree with me. I think they're pretty irrefutable, but again, that's my opinion. So the need for organs for transplantation is not met by the supply of organs from deceased donors. Outcomes of transplants with live donor organs are either equivalent or superior to outcomes of transplants with organs from deceased donors. Live donor transplantation is considered an ethically acceptable undertaking for the purpose of saving another's life. Live donor procedures are associated with medical, psychosocial, and financial risks to donors in the best of hands and under the best of circumstances. Live donors are exposed to considerable medical risk for absolutely no direct medical benefit to the donor. The only way to have a zero risk of live donor complications is to not perform live donor procedures. So I believe those to be irrefutable facts that will frame the discussion today. Ethical tensions arise between protecting live donors from unnecessary risk versus respecting live donors' wishes to accept risks. And I'm going to tell you that the first time I ever heard the term paternalism was from Peter Angelos, who's sitting up there. Before that, I had never heard that term before, so I guess he was the first person to ever teach me, not ethics, but how to be ethical, I guess. Versus donor autonomy. And so I think that that is where the balance needs to lie. And so I thought that I would list a number of issues that I believe frame the ethical debate around live donation. First, what defines unnecessary risk? Second, what level of unnecessary risk defines live donor safety? Third, should we consider live donor risk in isolation Or should we consider live donor risk in the context of recipient outcomes with and without live donation? Is live donation currently safe enough for donors? Conversely, has the recipient's risk-benefit equation tipped overwhelmingly in support of live donation, diffusing any further ethical deliberation? And finally, what constitutes the tipping point? And this is the question that I'm trying to address. What is an ethically acceptable risk threshold for live donation? So I believe that these are the issues that frame the debate. And so, obviously, in order to answer the question regarding ethically acceptable risk thresholds, the first question that comes up is, should protectionism of live donors be determined by paternalism or by donor autonomy? And I'll spend a significant part of the talk addressing this particular topic. So, first, some definitions. A risk is a numerical estimate, anywhere from 0 to 100%, typically based on aggregate data, either published or otherwise, used to inform a decision. Seldom stratified by uni or multivariate variables, comorbidities, or any other specifics. A complication is an undesired outcome of varying impact of it or importance. It is 0% to those who do not get the complication and 100% to those who do. And it may be influenced by uni or multivariate stratifying variables. When you put them together, the risk of a complication is an uncertain numerical estimate multiplied by 1, an uncertain influence of stratifying variables, and 2, an uncertain clinical, psychological, etc. impact should the complication in fact occur. And everybody knows what happens when you multiply uncertainties by uncertainties by uncertainties. And a threshold should be defined as a go, no-go decision point, presumably based on a global assessment of the risk of a complication. Imagine that. An assessment of an uncertainty times an uncertainty times an uncertainty defining a go, no-go decision point. So this is what we're talking about. What types of complications do we get? Well, there are preventable complications, which means that they could have been avoided with greater care. There are non-preventable complications, may not have been avoided with greater care, that fall under the category of stuff happens. Stratified variables define comorbidities and other specifics, and these may or may not be avoided with improved patient selection, in this case with improved donor selection. There can be medical/surgical complications, and these have been classified as minor to major, and they include death. And one of the first questions that comes up is a minor complication considered ethically acceptable in a live donor? I think we all accept minor complications in patients we operate on because they have a disease. But is a minor complication considered acceptable in somebody who is a live donor? There are physical and psychological complications that are measured by psychometricians in terms of quality of life. And there are social and financial complications, for example, insurability of somebody who is a live donor. So there are all types of complications that we're bringing into the mix. And so the first question is, should there be different acceptable risk thresholds for different complication types? For example, preventable medical or surgical complications, I think we could all agree that this should be as close to 0 as possible. There should be essentially a 0 threshold, or as close to 0 as possible, for preventable medical or surgical complications. I don't think we can say the same thing for non-preventable medical or surgical complications. I believe that the threshold for these should be at or below reported thresholds or benchmarks. And they should be risk stratified. And there should be higher threshold for minor complications, but I'm putting these as question marks. What about non-medical and surgical complications? Should the threshold be variable depending on the precise complication? So for example, disfigurement, the idea of having a scar after being a living donor, that's a complication. Should we have a higher threshold? Well, by definition we should, because 100% of our patients end up with some form of disfigurement. So it would make sense that there should be variable thresholds depending on what the precise complication is that we are talking about. And so I put forth a proposal that ethically acceptable risk threshold may vary depending on the complication type and depending on the impact, and that in fact there should be an inverse relationship. Complications are classified, and there's also a way to stratify risk, and these are not the same. So when we classify complications, we use some type of classification scheme, and we look at the severity grade and the impact on the recipient. We look at minor versus major versus death. We look at what needs to be done to address the complication. We look to see if there is a long-term disability that is associated with the complication. And in fact, almost everybody uses some iteration of the Clavian classification. I think we're up to the 5th iteration. Regardless of whether you look at the one that goes grade 1 to grade 4 or grade 1 to grade 5, there is a clear classification scheme that can be used, and this is particularly important when we're defining benchmarks. And then there's stratifying risk. There are donor characteristics such as age, comorbidities, and other donor specifics, the type of donor procedure, a kidney versus a living liver, a pediatric living liver versus an adult, a right lobe versus a segment versus a left lobe, and there is team experience. So there are a lot of other factors that might go into stratification of risk. So when trying to define a threshold, I think it's very important to have a very good idea as to what the grade, the severity, the impact of the complication is, and also to have some form of risk stratification that says it might be okay to get this type of complication in this type of donor, but it might not be okay to get that type of complication in another type of donor. And so I think what we've been dancing around is the issue of benchmarks. And so I think that if there are benchmarks, then we might say, well, the threshold is at or below the benchmark. And so I looked at the literature with respect to living donor kidneys. And we looked at perioperative complications. There's 22% minor, 3 to 6% major, 0.03% death. There is certainly an issue with renal function post-donation, with diabetes, with high blood pressure. There are long-term complications. There's clearly a higher rate of renal failure in African American females who donate, and in older age people. There are now SNPs that have been defined that put an African American donor at higher risk for developing kidney failure in the long term. Should this be tested routinely? I don't know what the answer is to that. We don't. I don't know if you guys do, but there's certainly SNPs that can be tested that might predict an African American donor from developing chronic renal failure in the long term. And so in 2008, 19.5% of living kidney donors in the US were obese. 2% had a history of controlled hypertension, and 3.5% had proteinuria. And in fact, this number has gone up and up and up over the years, and I would bet you that if you looked at the same numbers in 2012, those numbers are higher. Yet, and these are donors that are utilized as donors, not potential donors. And there is no national living kidney donor registry. So I think there are some data that we can use as benchmarks, but certainly not anything that you would feel 100% comfortable with. And I think the other message is that this changes over time. What about living liver donors? Well, adult-to-adult living liver, as you all know, there's an A2All consortium, which was formed by the NIH and HRSA in response to, one, highly publicized donor deaths, and two, high relative morbidity and mortality in living liver donors, especially adults. We published a series not long ago that looked at the retrospective and prospective experience. We had published a previous paper in 2008 that looked at the retrospective experience, and we looked at the overall experience. And it was really very, very interesting. So the bottom line is that 40% of adult living donors that received a liver graft experienced at least one complication. 19% experienced greater than one complication. 42% were Clavien 1, 48% Clavien 2, 1% Clavien 3. There were 95% of the complications occurred and resolved within 3 months. 7% of the complications emerged between 1 and 6 years post-donation. These were primarily psychologic complications and hernias. What was really interesting is when we looked at this series and compared it to the other largest series available, this number, 40%, was within 1% of a series out of Japan, of a series out of Pittsburgh, of a series out of Toronto, of our previous series, within 1%. And so the question that came up, and what I wrote in this paper is, have we defined the benchmark? And in fact, I suggested in that paper that we ought to stop measuring it unless we're trying to something new or different that's going to change it. By the way, the paper also demonstrated that this 40% did not change over time. So how many times do you have to measure something and get the exact same answer within 1%? And so there's no question that the risk of a right lobe is higher than the risk of a left lobe, and it's higher than the risk of a left lateral segment. So there's no national living donor registry for livers, A to all notwithstanding. All right. So what about the donors' perspectives? So when we've looked at quality of life, and we've looked at both physical and psychologic outcomes, it turns out that for both kidneys and livers, donors consistently report a greater or similar health quality of life pre-donation, both mental and physical, than the general public, and lower physical quality of life at 3 months that returns to baseline at 1 year post-donation. And again, you can measure this every which way. This comes up every single time. But that's not the whole story. In work that Elisa Gordon has done, she has shown that living donors have reported feeling social pressure to not speak negatively about live donation. They have reported experiencing complications that their transplant teams either ignored or dismissed. Also, there are certain predictors that are starting to emerge for poor mental health post-donation, and this is for both kidney and liver. The recipient health or well-being. Even though some series have suggested there's no correlation, it turns out in studies that we've done particularly focused on this, that there is a relationship, as you might imagine. If the person you donate to dies, you're not going to feel as good about donating as if the person is thriving. Donors with more pre-donation concerns, a psychiatric diagnosis, a graduate degree, there you go, greater than one complication, and a longer recovery period are associated with worse mental health post-donation. A hospital visit or an admission for donation-related complication is also a predictor of outcome. So even though we get this statement that donors feel really good about what they do and they do it all over in a minute, and they have this little dip in physical well-being at 3 months, I think if you drill down, you find that that's not the whole story. In fact, there have been some empirical, not many, studies of donor and provider perspectives of acceptable risk thresholds. Now, we hear that potential living kidney donors are more willing to accept higher long-term risk than potential kidney recipients or transplant providers. That's our own experience. I'm sure it's your experience. There's a study in the UK looking at 464 healthcare providers, patients, and donors. 8% consider risks to kidney donors to be negligible, 62% to be small or very small, 21% to be medium, and 8% to be high or very high. Study in the US, 43% of potential living kidney donors, 11% or potential recipients, and 6% of transplant providers would be willing to accept a 20-year incidence of kidney failure greater than 10%, which is 100 times the estimated risk. In the US, a study showed that 77 living kidney donors and 98 folks from the general population, there was a 74% willingness to accept a maximum of 1 in 3,000 risk of death, 62% of living kidney donors, 1 in 20 risk of death, 32% of living kidney donors, and 30% of the general population, half the risk of death. The risk acceptance correlated to how the question was asked. They actually studied, is the answer different depending on how you asked the question? And guess what? The answer was yes. There was a risk of death versus risk of survival. So if you said, here's a risk of death, as opposed to risk of survival, even though each one is 100 minus the other, the answer was different. Risk to themselves was higher versus risk to others. A close relative or a child, both higher, but not recipient prognosis. So I think we have some data as to what donors and providers agree is an acceptable risk threshold. And the answer is, it's all over the map. So what other factors might influence risk thresholds? Well, the first is, as we just saw, is who sets the threshold? Is it the donor? Is it the recipient? Is it the provider? Is it the hepatologist? Is it the surgeon, the nephrologist? Different answers. Is it institutional standards? We all know that our institutions tend to be risk averse. In the deaths that have occurred in live donors, I can tell you that institutions have either completely turned against the surgeon or they have stood behind the surgeon and been very supportive. And is it dependent on the institution? No. It's dependent usually on the relationship that the surgeon had with the institution prior to the occurrence of a donor death. The media. The media, in my opinion, defines better than anybody else what is an acceptable risk threshold. And what's their answer? 0. Because the minute you have a complication, you have the media all over the place demonizing live donation. And we saw this in Colorado, we saw this at the Lay Clinic. What about circumstances? The recipient's needs, the organ availability. I would submit that it makes a lot more sense to do a living donor in Chicago than it does in another OPO where you're transplanting patients with MELDs of 14. And what is the role of ethical norms and ethicists in this discussion? Ethical considerations in decision-making about pursuing live donation really depend on who has the ultimate authority to decide whether to pursue live donation and what are the factors that should be considered. And there are 2 papers that address this, paper by Miller, that found that there's a balance between 3 ethical considerations. Donor safety, what does this really mean? Anticipated recipient outcomes, and the need for a living donor versus the likelihood of receiving an organ from a deceased donor. Well, this makes perfect sense. There's a paper from your own, Juliana Testa. It is ethically appropriate to respect living donor autonomy. The point of this paper was that protectionism overemphasizes the risk to donors and underemphasizes benefit. And there was a sense of enhanced self-esteem. But the authors underemphasized the role of informed consent and the fact that protectionism is necessary because living donors often underestimate the risk to themselves and the willingness to accept higher thresholds and overestimate the benefit to recipients. And we all see this in our practices. In fact, we have to keep reminding living donors that just because they donate to a recipient doesn't mean the recipient is going to jump off the table and go run marathons. That is their expectation. And so you have to tone it down. And so in looking at protectionism, I think it's very important to emphasize the role of information and of the informed consent process. And what we get into is competing ideologies. In this continuum of protectionism, when living donors and providers hold divergent views on risk thresholds, there are ethical tensions that emerge between respecting the living donor's autonomy, typically a higher threshold, and providers' duty of non-malfeasance, which tends to go to the lower threshold. And so donor autonomy must guard against pressures to promote living donation, social pressures touting the safety of living donation. The act of offering living donation legitimizes it as a safe option. If we tell a living donor that we're offering you living donation, it legitimizes it. And it adds to the pressure that the living donor is feeling. The lack of alternatives for the recipient, especially in an OPO like ours, succumbing to technologic imperatives, incentives for transplant centers. You have to guard against all of these pressures if you are really going to let the donor make the decision. And paternalism. And we all have policies to protect living donors, whether we've thought of them or the federal government has decided that this is what we ought to do. The living donor advocate is an example for that. The New York State cooling off period, mandated evaluation protocols. More recently, the idea that you have to follow these donors, and if you don't do that to a 90%, which is, as we all know, impossible, then we are not really protecting the donor. And so there are all kinds of competing ideologies that straddle donor autonomy and paternalism. And so I think what all this highlights is the importance of communicating risk to potential donors who are trying to make a decision. And so it's essential that there be effective communication about the risks. And this has to be fundamental to the informed consent process. Okay, well, I just finished telling you that we don't really have a benchmark that we can effectively communicate in terms of what the risk is. And so in the absence of perfect information, which is where we are, transplant centers have to maintain a protectionist position by providing comprehensive and comprehensible information to optimize the informed consent process. And so I wanted to conclude early and hopefully have a discussion around some of these points. So the question is there an ethically acceptable threshold for live donor risk? And I think the answer is absolutely yes. There has to be, if we are to ethically accept the undertaking of living donation. And if you remember in my first slide, where I showed facts that nobody refuted, although you can refute them now, we said that live donation is an ethically acceptable practice for the purpose of saving somebody's life. And so if we think that it's an ethically acceptable practice, de facto, there is an acceptable threshold. The threshold has to lie at the tipping point between donor safety, defined as avoidance of unnecessary risks, and recipient benefit, and may change over time, and may change according to circumstances. For example, the needs of the recipient. This idea of unnecessary risks defining donor safety means that we have to define unnecessary risks. And in my opinion, they should be defined as either 1, exceeding benchmarks, and or 2, in the context of the transplant itself being truly needed or not truly being needed. And the idea that you shouldn't do a living donor transplant on somebody that you wouldn't do a deceased donor transplant on, should there be availability of organs. And that's an issue that's come up especially in the area of hepatocellular carcinoma. and or 3 for specific donor circumstances. For example, a mother to a child versus a neighbor to somebody else. And I think there's certainly a literature on that you folks have been a part of. The threshold should be informed by current benchmarks and by risk predictors that influence benchmarks. So risk stratification has to come in to benchmarks. You can't just say, well, this is the number. Well, what if, especially in the case of a kidney donor, what if the donor is 72 years old? So, we had, in the last couple of years, we had a 73-year-old patient who needed a kidney who came in and had 2 potential donors, a son and a grandson. The son was in his 40s, late 40s, and the son was in his 20s, the grandson. His wife was standing next to him. He was 73, she was 72. And he came in and said, these 2 people have volunteered to be my donor. What's the right thing to do? And we looked at the wife and we said, are you healthy? And we ended up doing a transplant from the 72-year-old wife to the 73-year-old recipient. We thought that was the right thing to do. That donor she was healthy as anything. They did everything together. And our thought was she had great kidneys, so why not use that kidney? So it could be that the decision is based on specific donor circumstances. That doesn't address benchmarks, because if you looked at benchmarks and stratifying information, you would say, well, of course, the risk is lower to the grandson, next to the son, and highest to the wife. And the risk can't possibly be 0. And again, that was one of the facts that I put up front. The only way to have a 0 risk is just not to do living donation. And we said that we think living donation is ethically acceptable. And therefore, by definition, the risk can't possibly be 0, except close to 0 for preventable complications. And so in the absence of perfect information and or of perfect communication, I believe that paternalism must dictate the level of protectionism. And I know that when I learned what paternalism was from Peter Angelos, what I also learned was that paternalism was a dirty word. And so I stand here in front of Peter Angelos with a lot of courage telling him that I think that paternalism has to dictate the level of protectionism. And Marky told me he learned it from you. That said, there must be, again, in my opinion, a protectionist emphasis on providing the best data available, as well as on making sure that data are translated into useful information so that the donor can make an informed decision. And that informed decision cannot occur in the absence of useful information. And so to answer the question about where does ethics fit in, I believe that the ethical focus should be on providing adequate information, not data, not simply data. If I give the paper that we wrote on complications of living donors to the average physician or surgeon, they would not be able to understand it. There are statistical methods that we used for that paper that go way beyond me. And I wrote it. But I had a team of statisticians that were supporting what we were doing. And I would submit to you that there's no way that anybody who didn't spend 2 years going over the data and talking to statisticians would have a clue what we were talking about. And so to expect our patients and the nurses who are talking to these patients and the social workers who are talking to these patients to be able to really extract useful information from these very complicated tables is absurd. And so I think that data are necessary because they certainly inform useful information, but without translating the data into useful information, I don't believe that we're truly informing our live donors. And so I think that the ethical focus, given everything that I've said, should be on making sure that decisions are based on useful information. So I want to acknowledge Elisa Gordon, who helped me put this together. In fact, she wrote this up for, I believe it was a piece in Current Opinions that we edited, and part of this was in there. And so she did a lot of work on this, and this is really an area that's close to her heart. The Comprehensive Transplant Center in Newton, Oregon, as you mentioned, CTEC, has been extremely active in a lot of these deliberations. I've got a list of references that are very easily readable, especially from the back of the room. But I'm happy if you send me an email. I'll be happy to send you the talk or in fact, you have it here, so you're welcome to it. So I would like to stop. Okay.
I think that the issue is still out there. You kind of talk on two sides. You talk about the need for paternalism and the issue of trying to get informed consent out of a patient. And given the complexity of the issues that you've described and the fact that the people in one of your slides where you're talking about potential donors don't even understand 1 minus X will get you to the same number versus survival and death. Is there any way to properly inform the donor?
So I think that's an excellent question, Mike, and the answer is yes. In fact, one of the things that we're doing, in fact, we're trying to get funding to do this, is to convert information into, or convert data into information that most people would be able to understand. So let me give you an example with the survival and death. So there's something called numeracy. You know, there's a number, 5%, 10%. And most people, and again, you could say, well, 95% survival, that sounds good, 5%, you know, so you can twist it around. So one of the things that Elisa has actually taught me is that if you put up a slide and it's got 100 little faces, and 97 are smiling and 3 are frowning, that means a lot to a person, and as opposed to saying 97%, 3%, and having that flip-flop. So there's a whole science that I confess I know absolutely nothing about, which I guess medical anthropologists know a lot more about, and she's talked to a bunch of people around the country. And what we're trying to do is to take the information or the data that is in the papers that have come out of A2All, for example, and the literature, not just A2All, and say, how do we convert that to a deck or some pictures or something that makes sense to potential donors? And so, for example, we're looking at the incidence of hernia, and there's different ways that can be presented. So I actually was thinking about putting some of those slides, but I wanted to just leave time for discussion. But I think that there are ways, now they may not be perfect, but there are certainly ways that I've learned about from Lisa and others, such that those data can be translated into something that is a lot more meaningful to people who are trying to make decisions. And that's just one example. There's all kinds of things that they use that are kind of cool.
Hi. Yesterday in Medical Grand Rounds, we actually had an interesting speaker from the Kellogg School who talked a lot about the future and how we're moving more into a patient-centered care model and the rights of patients to participate in decisions and also to have access to the information. When you and I actually walked out thinking it's interesting how this is going to intersect with transplant. I wonder what your thoughts are going forward, particularly in this issue, as you see our patients' involvement in decisions, where you see it going with respect to live donation.
So that's another excellent question. So I'm sure the person that was talking, I don't know who the person was, but I'm willing to put a wager that he or she was making a pitch for PCORI. So PCORI, as you know, is this new agency, and it stands for Patient-Centered Outcomes Research, something or other. PCORI, yeah. So, in fact, the old term was not competitive, but something effectiveness, comparative effectiveness. So comparative effectiveness, which is the big buzzword floating around for the last few years, has apparently become a dirty word. And Carolyn Clancy, as you know, just resigned as the head of AHRQ. And part of the transition with AHRQ in creating PCORI was that the reason that comparative effectiveness became a dirty word was that it took the patient out of the equation. And so there's a huge focus now on putting the patient at the center, patient-centered. In fact, so we had a talk from our own person who was pitching PCORI at Northwestern. He's actually the head of cardiology, Clyde Yancey, and he's on the panel that apparently looks at methodologies on which PCORI grants are going to be funded. And it turns out that if you want to get funded by PCORI, and you want to design some kind of an instrument, for example, or a strategy to test whether patients are getting the right information and everything, you will not get funded unless you have patients be part of focus groups, not only in your preliminary data, but in your proposal. And so this patient-centered approach has become pervasive, and in fact has become essential for funding from PCORI, which will probably be the biggest source. So this is a direct provision from the Affordable Care Act, and you may or may not know that the money to fund this is coming from insurance companies and from a lot of places that never contributed a dollar by mandate. There's a certain percentage per covered life that goes to supporting this type of patient-centered research. And so you're 100% right, and it's an excellent question. And so what's happening, and in fact, we're going to PCORI for funding for a lot of this because the NIH could care less. And so when you go to PCORI and you say, we want to have something that allows patients to understand the percentage of this and that, and by the way, we are proposing, which we are, a web-based tool to do that, the reviewers want to know what role did the patients have in designing this, and how are you going to test this with focus groups with the patient in the room and their families and everybody else. So as we talk about the other buzzword in Washington, which is shared decision making, so it's shared decision making. So it's patient-centered shared decision making. If you want to get a grant, if you don't have those 5 words in the first paragraph, they'll just toss it aside. But it makes sense. And so I think that it dovetails with Mike's question. I think if you really want to inform donors and you want to have shared decision making, then you better put the donor at the center of trying to decide what is it that they want to know and how do they want it presented. That being said, every donor that I talk to stops listening to me as soon as I tell them who I am. And they just want to do it and they don't care about the risk. So I'm not implying that, in fact, I'm implying the opposite. I'm implying that we could write beautiful grants, we could have great focus groups, we can include the donors all we want, and at the end of the day, they've already made up their mind as to what they're going to do the minute they walk into the office. So I think the challenge is how do you make sure that that doesn't happen, and that's the balance between autonomy, which is always willing to accept a higher risk, and paternalism, which is saying, wait a second, do you really know what you're getting into? And which you're proposing, doesn't make sense. You're coming in to be a living donor for your brother who has metastatic cholangiocarcinoma. I don't care how much you want to do this, we're not going to let you. And so I think that your two questions really dovetail very nicely into each other.
Yeah, thanks for a really balanced talk, actually. I was very appreciated the way in which you laid things out, and you were probably more of an ethicist than you claim to be. But I was wondering whether in the discussion of improving informed consent, your emphasis is maybe a little too much on cognitive processing of information, of making the data more intelligible to people. One phenomenon that's been seen in the prevention literature and now in research literature is something called unrealistic optimism, in which persons will say, so I know what the data are, but I'm certain I'm going to be the one who will avoid the bad outcome or get the good outcome. Smokers, for instance, are unrealistically optimistic about their chances of avoiding lung cancer, and people who enroll in phase 1 clinical trials are unrealistically optimistic about their ability to avoid bad effects from the chemotherapy or about their chances of actually benefiting. And I wonder whether in this particular phenomenon people have looked at that, whether it's all about cognitive processing of information or perhaps this cognitive bias, which once the information is there, still blocks people from being able to appreciate the actual risk.
Right. So, again, this is not an area that I consider myself to be an expert in, but I will tell you, and Juan Carlos Caicedo is here, and he runs our Hispanic transplant program, and I can tell you anecdotally, there's a guy named Mike Wolf at our institution who's a big kind of health literacy guy. And he did this study that I thought was unbelievably genius. And it turns out that Hispanics had an incredibly low rate of screening colonoscopies and a very high rate of colon cancers that were advanced at the time of diagnosis. And so what Mike did is he put together this campaign, which was, so they did the focus groups and they tried to figure out, why is that? And they came up with two major reasons. Number one is that in their belief systems, this particular community believed two things. Number one was that if you touched something that was cancerous through an operation or through a scope or something, it would immediately disseminate. And the second belief was that people didn't get colon cancers if colon cancers didn't run in their families. So if your father didn't have colon cancer, you're fine. And these were embedded in their belief systems. So Mike designed these cartoons where there was some kind of cartoon and there was a narrative about there was no family history, and then there was a cartoon about the colonoscopy, and there was it was almost to the level that a Sesame Street level. And he introduced it into different communities with very careful monitoring. And in fact, had a couple of Hispanic television personalities or radio, I don't remember the details, kind of promote this. And promote the cartoon, promote this thing that was very easy for people to understand. Not a bunch of numbers about percents in Hispanics, or not the data, but information based on data. And the rate of screening colonoscopies shot through the roof. So again, I'm not an expert in this, but it makes sense, right? If you have fears, and a lot of this goes back to what your belief system is, what you fear, what you don't fear in case of a donor, and somebody is showing you in a very simple manner that these are the risks and that this is what happens in a way that you can really understand it and process it, then it's been shown, and I understand from him that this is, he didn't invent this, that, this has been shown in other areas. So I think there is something to be said for communicating. There's always going to be biases. I mean, like I said, none of this is going to be perfect, but I think that the effort, and again, the ethical focus, should be on making sure that everything possible has been done to make sure that the person who's making the decision is at the center of the decision making, that they've participated in designing the instruments that are used, and that that useful information is transmitted to that person so that when they make that decision, you can say with a clear conscience that you've done everything possible to educate them and not just show them some paper that somebody wrote that might as well be in a different language. So yeah, I think there are biases, but I don't think that means that we shouldn't be trying to do what we just outlined.
Thanks again. That was really an excellent presentation of data, and the insistence on drawing on that data and utilizing it is certainly something we can all agree with. I wonder, though, I was chatting with Lainey on your early distinction between the minor and major complications, and part of it is minor to whom or major to whom, and because what may be major by these statistical criteria may be minor, and conversely to specific individuals. That's the limitation of generalizations.
So let me make sure, so maybe I need to expand on a little bit. So in fact, I don't favor the latest iteration of the Clavian classification because I think it leaves out something very important. So the one that we argued in this paper, and in fact we wrote a piece in gastroenterology because we were criticized on the previous paper of using the older version of the Clavian classification. So the one that we used has 4 grades, and it's not to anybody, it's the same. So it's number 1. Minor means that you get an extra medication. 2 means that a procedure has to be done. 3 means, and this is where it starts to diverge from the Dindo classification, from the Clavian Dindo iteration, means you have a long-term disability. And 4 means you either have to have a liver transplant yourself or you have a transplant. The 5-grade classification, the Dindo, does not anywhere include the presence of a long-term disability. So it's you get a drug or you get a procedure or there's some other intervention or this or that, but there's no, and so in livers, one of the complications we see is brachial nerve problems, right? So those patients have a disability that doesn't require an intervention. So under the Dindo classification, they would be like a grade 2, and they might consider and minor, whereas we consider it major because 3 or 4 is considered major. But one more point about that, because when we looked at the longitudinal data, and there was a lasting disability, it turns out that it depended when you looked at it, because we looked at in this paper the rate of resolution of some of these complications. And so you might have looked at one snapshot and say that's a permanent disability, and then look 2 years later and that disability was gone. So it's no longer a grade 3, it's gone to a grade 2.
But these are still all medical complications
Yes.
that can be objectively defined. And the relationship between those and their impact on particular individuals isn't alluded to. And I'm not entirely sure that you could test for that anyway, but that's really real. And in conjunction with that, I wonder about patients, granted your data, which was really important data, about the sequelae for these donor patients. And you said, you did allude to psychological sequelae as well. What I wonder is, did those people who experienced maybe some disappointment, as well as medical effects, did they regret that decision to donate?
Yes. So first of all, you should know that the second funding cycle for A2All, which is ongoing, I think we're in the 3rd year of a 5-year funding cycle, is actually analyzing exactly those questions. So the focus on the second funding cycle is on measurement of various different types of quality of life metrics. So In fact, Dave Sella at our shop, and then the folks at Pittsburgh, and there's a lot of very good groups looking at this. But I think that in general, we've learned some things about the psychological issues. We've learned that for the most part, they were predictable. Had somebody done a thorough psychosocial evaluation of the potential donors. We've learned that dipping in psychological well-being was associated with a bad outcome, but not to a significant level and not persistent. But we learned that if you had any kind of a psychological flag that didn't go up because nobody looked, in retrospect, and the best example of that, which wasn't in this study, but there was a donor death reported by the Omaha group in a pediatric living liver patient. And some very healthy looking cowboy walked into Alan Langus's shop, said, I want to be a donor. I don't really care who it goes to. Take a piece of my liver and give it to them. And they looked him up, and he owned a ranch somewhere in, I don't know, that part of the country. Seemed like a reasonable guy. And they worked him up. They didn't ask a lot of questions. He was healthy as anything, and did the donor. And a year later, he committed suicide. And turns out that this was all planned, that in fact he had wanted to do a good deed before committing suicide. Turns out he had told this to a local therapist who hadn't thought much of it and didn't know that he was being evaluated for a living donor. So this was completely planned. He in fact had planned when he committed suicide on the 1-year anniversary of living donation. So I think
So Mike, great to see you. Great talk as always. And I'm not sure that I taught you anything actually about ethics. I think I learned a lot from you. But
thank you, Peter. Not true, but thank you anyway.
Let me ask you, with respect, I think your focus on informed consent is an excellent one. And what I'm just curious about is it seems to me that in standard medical surgical therapy, there's one kind of philosophy that our responsibility is to give patients the opportunity to be informed. And if they don't want to be informed, that's okay, as long as we've given them the opportunity. There's another philosophy that says, well, if they're not informed, then they can't make a decision that's informed, and therefore I can't offer it to them. And so I guess my question is, as you look at living donation, where do you fall in that, in those two camps? Is it enough for someone to come in and say, Dr. Abecassis, I want to do this. I don't care what you say. You can talk till you're blue in the face. I want to do it. Can that still be an adequate informed consent?
No, not for living donors. So I agree with you that if you're operating on somebody and taking a piece of their liver out because they got a tumor, or taking an adrenal out because there's something wrong with them, you've already done the risk-benefit analysis in your own mind. You've biased the decision by telling that patient you've done the risk-benefit analysis and you believe they're better off with that piece of liver gone or the adrenal gone. And I don't think you worry too much about whether they truly understand. I mean, you should, but you really don't, let's be honest, because you know this is the right thing to do. A living donor, I said in one of my facts, there is no medical benefit, zero. And by the way, I was very careful to say medical benefit, because I also happen to believe that there is zero psychological benefit to them. And if somebody tells me that they feel good about being a living donor, I will come up with a dozen things that they could feel really good about that would not involve giving away half their liver. And so when somebody tells me that there's a psychologic benefit to being a living donor, I have to tongue-in-cheek nod my head and think in my own mind about what kinds of things might give me the kind of pleasure that I might derive from being a living donor or more without giving away half my liver. So, but I did say medical because I didn't want to get people, enraged.
in your head. It's more. Mark?
Probably the same list that's in your head, Mike.
Mike, thanks for a great talk. We really appreciated it. I think on your first slide, your fact sheet, near the bottom, you said for adults, or no, in general, a right lobe had a higher risk than a left lobe and higher than a left lateral segment. In an earlier talk in this series, John Roberts came out and said one way to reduce the overall risk for adult donors would be to do more left lobes, in part because of that safety margin compared to right lobes, and that in marginal cases where we're using the smaller graft might put the recipient at some degree of increased risk of small for size. John was advocating that the balance be towards the donor's safety rather than the recipient's in those marginal cases. And I think he's going to go to print with this shortly. You may have heard it in a conference.
I'm very well aware of the
you
data.
want to just comment on that
Sure.
as risk reducer?
Yeah, so it's not always as it's told. So John and Jean Iman and Alan Langness and a couple others have been pushing the left lobe and sometimes even the lateral segment in patients instead of the right lobe in adults. And there's a whole bunch of stuff that you have to do. Splenic artery ligation, a shunt in the recipient. It's not as easy as it sounds. We've actually done a handful of those. And I think you really have to go back and look at data. And in fact, in the A12 paper that we published, I think there were about 30 left lobes and 710 right lobes, so it's not really a fair comparison. But the complication risk for left lobes was actually higher than it was for right lobes. It was certainly not statistically significant because of the numbers, but it was not lower. In other series from Asia, they've shown left lobe complications being slightly lower, although they don't have the kind of data that we've been able to come up with. And I think, and I've talked to John about this, and I've talked to Jean about this, we do the right lobectomy essentially through a small incision. We do it laparoscopically assisted, and we believe in our hands that the morbidity of a right lobe is probably lower if you have the experience and you've done it before than the left lobe. And I'd actually be interested in Mike's impressions on this as a liver surgeon. I find left lobes difficult. And you're going through the same Cantley's line, so it's the same parenchymal transection. Whether you take the caudate or not really complicates it. I would submit that if you take the caudate, it's a technically more difficult operation and riskier than a right lobe when you don't take the caudate. So I think we could sit here all day, I think, and argue back and forth. I think that it's provocative that John has sort of taken the approach of pushing left lobes, and certainly at UCSF they've started to change the way that they do them. If you look at the recipient, it's a real problem. I mean, these patients get ascites, they get jaundiced, they've got shunts you got to shut down later on. Sometimes you do, sometimes you don't. So in the overall, again, one of my facts was that you should probably take the donor risk in the context of the recipient needs. And I think that as we have done that analysis, having done a bunch of these left lobes, it is our impression today that it's safer to do a right lobe than a left lobe, or just as safe from the donor perspective with much better outcome on the recipient side. Now, I applaud John and Jean for pushing this, and hopefully we'll learn something from it. And actually in the current A2L, which UCSF participates in, one of the ancillary studies is actually to compare the outcomes and risk of left lobes versus right lobes. Yeah.
Juan Carlos?
I just want to make a comment in the informed consent. Usually we start talking about from the perspective,
Speak loudly, 'cause the rest
perspective of the health provider. Then why the physician wants to inform to the patients and the data they want to inform and how we're going to inform them. But sometimes as well, I think it's very important to think what is important for the patient, the potential donor, potential recipient, and consider what is the background. Because here in U.S., as we have a very diverse population, and actually now minorities are majorities in the waiting list, for example, for kidneys, to have that component of cultural competency or congruency. Because sometimes when we're informing the patient in a standardized way, and many centers are doing kind of a standard way to approach every single patient, there are no understanding. It's because there is a cultural barriers or language barriers, and we are not addressing all of these. Then I will add that probably it will be important also in all of this effort, not only to improve the quality of the information that we're providing, but making sure that it's in the cultural context and the language of these people to make sure that they understand. Many times in the clinics, the nurses are saying, oh, this patient is not compliant with this or that. But it's not because they don't want to comply. They didn't understand what they were talking about. Then I think that cultural competence and congruent part is important in the informed consent.
Thank you. And just, I agree, Mike. You know, a lot of it in terms of right, left, most of us do more rights than lefts, and so some of it is just experience, right? I mean, we're more familiar, easy. We could either of us could do a right lobe pretty much, you know, in our sleep, and you know, not have a problem with it. Left lobes, we don't do as many of them. We'd have to at least be half awake to do a left lobe. So there's just. But I think in both of our hands, probably we've seen essentially the same level of complications in right lobes and left lobes. So I don't know that there's a big difference. That has been my issue with that whole concept too. Is that in most of our experienced liver surgeons' hands, the right lobe and left lobectomies have about the same complications.
Well, remember that the Asian surgeons started out with the left lobe.
Yes, and moved to the right.
And moved to the right, and they haven't gone back.
Right.
And these are guys that really know how to do a left lobe.
Yeah.
So I think you have to learn from people. You know, it's like, they'll learn.
Yeah.
John will learn his lessons.
All right, Mike, once again, thank you very much for coming.
Thank
Really
you.
appreciate it.